Welcome to ASGE's second EOE for APPs webinar. Our sincere thanks for participating in this evening's program, which will address therapy fundamentals, including PPI, topical steroids, biologics, and diet. My name is Tom Cornegay, and I'll serve as your facilitator. If you haven't done so, please scan the QR code on the screen to complete the pre-course assessment, and I'll pause for a few seconds so you can get that done. Please note that AI note takers and recording bots will not be permitted during the webinar to ensure we maintain a private and focused environment. So please disable those tools. You can ask questions during the Q&A session by clicking the Q&A tab at the bottom of the screen. Once you click that tab, you can type your question and hit enter. A recording of this webinar will be posted on GI Leap, which is ASGE's learning platform, and you'll receive an email with a link to the recording. Also note that this webinar is supported by an educational grant from Sanofi and Regeneron. Tonight's faculty includes two of the nation's leading EOE experts, including Dr. Nirmala Gonzalez, who is a professor of medicine with the Feinberg School of Medicine at Northwestern University, and Dr. Amanda Muir, who is a pediatric gastroenterologist and associate professor of pediatrics at the Children's Hospital of Philadelphia. It is now my pleasure to turn the program over to Dr. Gonzalez.
Hi, good evening, everyone, and welcome to our program. We will be discussing therapy fundamentals, PPI, topical corticosteroids, biologics, and diet. Okay, learning objectives for the program are to explain the goals of therapy in EOE, to outline the various medical therapies and mechanisms of action, to review the effectiveness of various diet therapy approaches and their approach to food reintroduction, and to discuss the importance of maintenance therapy and provide guidance for successful long-term remission. So when we talk about treating EOE, we really want to think about a treat-to-target approach. What is our goal for our patients? Well, certainly one, we want to improve symptoms. We want to have resolution of dysphagia without the need to avoid food based on texture. We want our patients to be able to eat anything that they want. We don't want them to have to drink a lot of water to push the food down. We want improvement in histopathology, so improvement in that esophageal eosinophilic inflammation, ideally getting those eosinophils under 15 eosinophils per high-powered field. And we certainly want improvement in endoscopic changes, improvement in those inflammatory features that we see in the esophagus, such as the exudates and the furrows and the edema, as well as the rings and strictures. And ideally, we want the stricture diameter to be above 15 to prevent that dysphagia and food impaction. So when we think about initial choice of therapy, there are a lot of things to consider. First, the efficacy of each of these agents, as well as the adverse events of each of these agents. We want to talk to our patients about their preference and their goals of care. Certainly, disease severity can play a role in which choice we pick up front. Unfortunately, insurance coverage definitely plays a role sometimes in which medication we can use. Dietary resources are really important. You want to make sure that patients have access to things that they need if you're doing dietary therapy. And most importantly, when we're talking about initial therapy, shared decision-making with our patients really guides those treatment decisions. We want to go over pros and cons of each of these therapies, listen to their goals of care, and then try to align on the best choice that they want to pursue for their care. So when we think about therapeutic targets in EOE, it's really helpful to understand what's happening below the surface. And I'll walk you through this and walk you through how each of these therapeutic targets act. So when we think about EOE, Foods mainly and some air allergens traffic across that esophageal barrier. Patients with EOE tend to have a disordered epithelial barrier. That sets off certain alarmins and signals, including IL-33, TSLP, which then interact with certain inflammatory cells called Th2 lymphocytes, which set off various signals such as TGF-beta, IL-4, 13, and 5, which then through various mechanisms recruit eosinophils, mast cells, and other inflammatory cells to go to that esophagus where there's eosinophilic inflammation, loss of barrier function, and ends up with remodeling of the esophagus and those changes in the esophagus that we see, scarring and strictures, which ultimately lead to the dysphagia and esophageal dysfunction that we note in our patients. So how do each of these things work? Well, food elimination diet essentially eliminates that trigger response, taking out those food antigens and preventing that downstream cascade. Proton pump inhibitors work through Th2 mechanisms by downregulating one of the signals, eotaxin 3, and works as an anti-inflammatory mechanism. Topical corticosteroids also can work as an anti-inflammatory mechanism and decrease local cells like eosinophils, and Dr. Mira will talk about that further. And dupilumab works to target and block two signals called IL-4 and IL-13. So I'm going to start off by talking to you about proton pump inhibitors. Now, this is data from the AGA and Joint Task Force recommendations back in 2020 on PPIs. They looked at 23 studies with over 1,000 patients who were treated with PPIs, and the efficacy was less than 15 eosinophils per high-powered field. And they found that using PPIs resulted in an overall effectiveness of 42%. So the use of PPIs is a reasonable first choice and a first step in treating EOE. Now, many patients are concerned about safety of PPIs, and that's always a conversation that we talk about. But this recent study here really highlighted safety of PPIs over 3 years. This was a randomized controlled trial of patients who were receiving rivaroxaban or aspirin who were also on a PPI therapy. And what you can see here are all the concerning things that patients have heard about, from chronic kidney disease, dementia, fractures. None of them really panned out as a risk. The only risk that was significant was other enteric infections, so stomach bugs that are slightly higher risk with PPI use. But this study really showed the safety of PPI for long-term use, and that helps patients wrap their heads around the use of PPI as one option for EOE. So what are practical tips for PPI use? Well, first and foremost is to understand the potential non-acid mediated mechanisms of PPI and communicate this to our patients. It is so important to tell patients why we're using PPI, because a lot of times patients will just think we're telling them that they have reflux and that's what we're dealing with, where that's not the case. PPIs work in various ways to suppress that Th2 eotaxin secretion as an anti-inflammatory way. It helps to improve esophageal barrier function by blocking even normal physiologic acid, and it can improve epithelial homeostasis. So basically reestablishing some of the healthy cells in that esophageal epithelium. So generally we start with twice a day dosing if effective. So that means the equivalent of omeprazole 20 milligrams twice a day or omeprazole 40 milligrams once a day to achieve response. Over time, some patients ask about de-escalation of that dose, which is possible, but some may lose response with that lower dose. So we may have to increase that medication if that happens. Optimally, we want to perform an endoscopy no matter what treatment we pick. And with PPIs, we say usually after 8 to 12 weeks of being on a PPI, we'll repeat that endoscopy to make sure that there is response. In addition to achieving histologic effect, one thing I wanted to add is that PPIs have been shown in larger scale studies to improve endoscopic changes as well. So it can improve some of those endoscopic features of the esophagus as well as increase that stricture diameter. So now I'm going to hand the baton over to Dr. Muir, who will walk us through topical corticosteroids and biologic therapy.
Thank you very much. And so for topical corticosteroids, the AGA Joint Task Force, when looking at 8 randomized control trials evaluating topical corticosteroids, the overall effectiveness for topical steroid agents, and these were a mixed bag of which agents, and we'll get into that, was about 61%. And so when we talk about what topical corticosteroids are, what do we mean by that? Because there are many different options. And for years and years and years, we used off-label approaches. So we used asthma medications off-label for EOE. And so when we think about what are the various topical steroids that our patients may be on, there's a group of patients who might be on a swallowed fluticasone inhaler, and this has to be the HFA inhaler. And we instruct patients to place the inhaler in their mouth and not use their mask and spacer as they're often instructed to if they have asthma, but actually put the whole inhaler in their mouth and wrap their lips around the inhaler and spray 2 sprays in the back of their throat and swallow, and not breathe when they do that, so that none of the mist is inhaled. You actually want to have it swallowed so it goes down the esophagus. And so that's one approach. The next approach that was used historically was these budesonide ampules. And so these are the medications that patients who have a nebulizer at home where they nebulize budesonide for asthma and inhale it in a nebulizer machine. And instead of using this in a nebulizer machine, they take the ampules and mix with either 5 packets of Splenda, which has been historically tested as giving the budesonide a nice viscosity in order to swallow, or a teaspoon of honey, a teaspoon of applesauce, a teaspoon of maple syrup, something to make it viscous and sticky, and then the patients swallow it. And then the third formulation is the FDA-approved formulation, which is the budesonide oral suspension. And this comes in a packet, as you can see here, and the patients kind of can shake the package, open it up, and it's already the right viscosity and already pre-made, and they can swallow that. And so for all of these things, there are different dosages and different patients who these are right for. And so which topical steroid the patient's on depends a lot on their age, as well as because the budesonide slurry that is FDA approved is only FDA approved for patients 11 and up, and also sometimes what their insurance will cover. And so when we look at the clinical trial data for the budesonide oral suspension, and it's important to note that when these trials were done, they were done with a much more stringent eosinophil cutoff than we use in clinical practice. So in order to be considered as having a histologic response, the patients actually needed to be under 6 eosinophils per high power field when they had their endoscopy. And so when patients when looking at this, considering even that with this strict criteria, patients on the budesonide oral suspension had 53% of them responded, whereas only 1% of the placebo patients responded. And then when we look at the symptom response in these patients, so how many of these patients had a reduction in their dysphagia scores, you can see that over 50% indeed had a reduction in their budesonide of the patients who were getting the budesonide oral suspension when compared to placebo. And so one of the things that often comes up is, well, are these topical corticosteroids safe to take long term? And the answer is yes. So this is a study looking at the patients who were in the budesonide oral suspension trial and followed them out through 48 months of treatment. And as you can see, the proportion of patients who had a maintained response rate was still about 50%. And again, they're maintaining a response rate that's probably even more stringent than we necessarily use in clinical practice, having less than 60 eosinophils. And what you can also see is that in addition to having a response histologically, these patients also had a change in baseline and their total ERAF. So looking at their endoscopic scores, they had a maintained decrease in their endoscopy scores over time when compared to placebo. And so what do we think about as the side effects to budesonide oral suspension and all of these topical steroid preparations? And I think the number one side effect that we see is an oral or an esophageal candidiasis, which ranges from 7 to 12%, depending on the study you look at. And usually this is the patients who have this are asymptomatic, and we find it when we do our repeat scope to assess for disease response, and it is very treatable with antifungal medications. In the study itself, there was no increase in adrenal suppression compared to placebo. But as a pediatrician, I do think we have to think about our patients, especially our patients with comorbid atopic diseases who are inhaling steroids as well as swallowing steroids for EOE. And the group out of Colorado, and Sue et al. In 2017 published their experience with 106 pediatric patients on topical corticosteroid preparations, and all of them had morning cortisols checked. And in the 5 patients who did qualify as having adrenal insufficiency, all 5 also had asthma and were on inhaled steroids as well. And so this brings into the picture of, in your patients who are high risk, we really need to be screening and making sure that we aren't giving patients multiple types of steroids and not monitoring them carefully for these types of side effects. And so how do we tell patients to take them, regardless of which formulation they choose or that gets approved for them? And so when patients take these corticosteroids, the most important thing is they have to be NPO for 30 minutes after ingesting the steroid. And I often compare this to putting lotion on your hands and then would be washing it right away if you have anything to eat or drink. And so whether they're doing the inhaler or one of the various slurries, they take their medicine and then nothing touches their lips, not even to brush their teeth for 30 minutes. And again, age and weight need to be a consideration when choosing which formula. The smaller children cannot do the inhaler. It is very hard to tell a small child to not breathe while they're getting a medication. And also the budesonide oral suspension only comes in 2 milligram packs, and that may be too much for younger children and younger populations. And so thinking about the different dosages that are being prescribed is important. Again, we need to evaluate for comorbid atopic conditions and consider screening everyone for with AM cortisols, especially after they've been on this for months and years. And then there's recent evidence that some patients, especially those who are on twice a day dosing, may be able to consolidate both doses to 1 time a day. So we often had patients on 0.5 milligrams twice a day, and young patients, and we've now started to be able to consolidate that to 1 milligram once a day instead of having twice a day dosing, which is makes quality of life better. And so now moving on to biologic therapy. When we think about where the biologics that are currently have been studied and are the things we think about, originally there were some early clinical trials thinking about decreasing the amount of IL-5, which really drives eosinophil recruitment and maturation, or biologics that were targeting eosinophils, and these have been largely unsuccessful. But what has been successful in multiple clinical and more recent clinical trials is attacking the IL-4 and IL-13 pathway. And so what does dupilumab do? And so dupilumab inhibits the IL-4 receptor alpha, which is a receptor for both IL-4 and for IL-13. So it effectively, with one antibody, you're blocking both cytokines. And we do think both of these cytokines are important in the pathophysiology. And so being able to take out both of them has proven to be very successful. And so when we look at the results from the clinical trial, and this is again using a stringent eosinophil count with less than 6 eosinophils per high power field. You can see in patients who, in part A, which was 6 months of receiving dupilumab weekly, 64% of the patients who received weekly dupilumab responded. And then when we look at part B, the patients who were on placebo then transitioned to either a weekly or an every other week dose. And you can see that these response rates of the patients receiving medications ranged from 70 to 100% once everyone was receiving dupilumab. And so when we think about the symptom response in dupilumab, and this was studied both in a weekly and an every other week cohort, originally. And as you can see, this is the symptom score and the decrease in the symptoms as the medication is given. And as you can see, the patients who received weekly dupilumab had the most decrease in symptoms, and that was the one that was statistically significant. And so that's why dupilumab is currently dosed weekly for those patients who are a greater than 40 kilos. And so when patients often ask, can I take it every other week? Or I often say that they may not have the same symptom response as they would if they were taking it weekly. And so in our younger children, and so dupilumab is a weight-based medication, and it has recently been FDA approved for ages 1 and greater than 15 kilos. And so there was a specific trial that studied this in the younger age groups, ages 1 to 11. And as you can see in the patients who received the higher dose, there was a 68% response compared to the patients who received the lower dose, still had a 58% compared to placebo. And this study had very rigorous secondary endpoints beyond just looking at eosinophil counts. There was also thinking about histologic measures besides from eosinophil counts, like epithelial markers, as well as other histologic grades. There were endoscopic measures, as well as transcriptome, and all of these markers achieved a positive outcome and healing. And the main adverse effect across all of these dupilumab trials is really the injection site reaction. And this can happen in up to 20% of patients. And it can come in the form of like a big hive or a big welt at the site of the injection. And it can, and while it might be red and swollen for a short period of time, it does not mean that you can't keep taking it. So even if a patient calls and says, oh, I have this rash that I got the day after I had my injection, we usually reassure them and tell them they can continue taking it as long as the rash self-resolves. And other adverse events include things like myalgias, are important to look out for. And we do also tell patients who have comorbid eczema that there may be some conjunctivitis, as patients in the eczema trials did have some conjunctivitis, and it was really more of a red eye. And so these are the current FDA approved dosages based on weight. And as you can see, at 15 kilos, it's 200 milligrams subcutaneous, whereas once you hit 30 kilos, it's 300 every other week. And then at 40 kilos and above, it's 300 milligrams weekly. And it's important to note that this is a higher dose than in eczema and asthma. And so, and that might be important, especially if you're partnering with your allergist. You're going to want to make sure you use the EOE dosing for a patient with comorbid atopy. And so the other thing is that the shot is painful. The more you can make the shot room temperature prior to giving it, the better. So things like taking it out 24 hours in advance and not just 1 hour in advance is actually very important. Many patients feel that the syringe, it has much more control and you can actually instill it much slower than using the auto injector. We've had good success having patients use a vibrating tool called a buzzy at the site of the injection while they're getting their shot to kind of distract those pain sensations. And so, why do we have to have patients on medications forever? So anytime I tell a patient, and walk through any of these options, I often get asked immediately thereafter is, do I have to do this forever? And my answer is usually we have to do something forever, and we have to treat this. It is a chronic disease. They will likely have it long term, but what we have to do is keep it under control. And just because you pick diet therapy now doesn't mean you have to be doing diet therapy when you get to high school or college and beyond. And just because you pick shots now doesn't mean you have to take shots forever. This is what is the best therapy for the place you are in your life right now. And so why is it so important that we continue these therapies? And I often show patients the esophagus and what we're trying to prevent. So in the healthy esophagus, it's nice and flexible and bendy. And unfortunately, with chronic inflammation over time, the esophagus not only becomes swollen and hot and bothered, but also starts to scar down and form a stricture. And that's really what we're trying to prevent. We're trying to prevent the esophagus from becoming extremely scarred down, where you need dilation, where there's recurrent food impactions, and where there's really esophageal dysmotility. And then patients start having chronic dysphagia even in the setting of getting their esophagus to a good place because there is a scar that may need to be dilated. And so, how do we know this? And I think this is a lovely study that was done by Runge et al., where they looked at the dilation-free days of patients who responded to topical steroids compared to non-responders. And as you can see, the patients who were not able to achieve histologic remission and get their eosinophilic esophagitis under control were much more likely to need a sooner dilation. And so there is some benefit to getting this disease under control, hit it hard, and then hopefully you won't need as many of these dilation procedures.
Okay, so now I'm going to hopefully take control over these slides and walk you through diet therapy. Okay, great. So the goal of diet therapy, first of all, remember the rationale for diet therapy. We think about this as being a food antigen-driven disease, not a classic food allergy that we think about where people are exposed to a peanut and they break out into hives and can't breathe, but it's a chronic exposure to common foods that are driving this inflammation. So eliminating these foods is really what helps. And when we think about goals, it's one, to improve disease activity. We want to improve that esophagus. We want to identify the causative food triggers because we want to know which of these foods is really driving this response so patients can tailor that diet effectively. We want to prevent complications of disease activity, such as strictures, as you just heard from Dr. Muir. The longer time patients have inflammation, the higher likelihood they're going to have strictures. So that's one of the goals of diet therapy as well. In addition to improving or maintaining nutritional status, as well as health-related quality of life for our patients. So we think when we talk about diet therapy, it's important to just do a walk down memory lane and evaluate the history of where diets started. And the first study really was in children back in the mid-1990s, where they exposed children who had EOE to an elemental diet, basically taking all antigens out of their diet, and found that they went into histologic remission. And that was the first study to really link these food antigens to EOE. Because diet therapy can be difficult, elemental diet can be very difficult to do because it's formula-based diet. Dr. Leah Kors and the group at Children's Hospital looked at targeted treatment, meaning using allergy testing directed diet to guide diet therapy. Shortly after that, Dr. Kagawala at Children's Memorial looked at an empiric elimination diet with a 6-food elimination, eliminating milk, wheat, soy, egg, nuts, and seafood, and found that to be effective in children. Our adult group looked at the same 6-food elimination diet, found it to be effective in adults, as did the group in Spain. A single food elimination diet using milk only was described by Dr. Kagawala in 2012. A 4-food elimination diet eliminating milk, wheat, soy, and egg shortly thereafter. A step-up elimination diet, which we'll talk about in a little bit more detail, was described in 2018. And then the first randomized diet study, a 1 versus 6 food in 2023, and a 1 versus 4 food in pediatrics in 2025. So in a very short amount of time, we've really evolved in terms of diet therapy. So I'm going to walk you through some of this data. So when you look at the AGA and Joint Task Force guidelines, this is the guideline on dietary treatment for EOE, and they pooled all the diet studies that were available at that time. Now you see that elemental diet is by far the most effective, 94%, at achieving that histologic response of less than 15. But elemental diet is a solely based amino acid formula diet. It's hard for patients to do, both from a cost standpoint, palatability standpoint, but really when you're starting with just amino acid-based formula, there's a really long reintroduction process in terms of adding all those foods back. And that can be pretty challenging. So we've really moved away from the use of the elemental diet. We've also moved away from allergy tested directed diets. All current guidelines now, including the recent ACG guidelines, suggest not doing allergy testing directed diets because there is a poor correlation with allergy tests and what food triggers are, because allergy tests really are designed for anaphylaxis. So the favorite approach was the empiric elimination diet. And at the time of these guidelines, the studies that they looked at were just that 6-food elimination diet, which was effective in about 68%. So when we look at those pool studies here, lots of different studies, and these studies here were that 6-food elimination diet. And what you can see is that the combined effectiveness of all of them hovers around 72%. So if we're looking at an endpoint of less than 15 eosinophils, most of the studies will achieve this in about 72%. There's been several other empirical elimination trials that have been published since 2014, and the results really don't change much. So what are we eliminating on these diets when we're talking about this 1 versus 2 versus 3? So let's walk through that. When we think about a 6-food elimination diet, it's elimination of cow's milk, wheat, egg, soy, peanut and tree nuts, fish, and seafood. When we're looking at the top 4 antigens, it's eliminating milk, wheat, egg, and soy. When we're talking about 2 foods, it's milk and wheat. And 1 food for kids, it's traditionally cow's milk, and for adults, it can be cow's milk or wheat, depending on which single food you're trying to avoid. When we pull all this together and we look at efficacy, traditionally, as in the graphs I've just shown you, the 6-food elimination diet tends to have about a 70 to 80% effectiveness, 4 food about 60%, 2 food about 44%, and a single food, depending on the study you look at, anywhere from 30 to 40%. So you would think that eliminating fewer and fewer foods based on this might decrease that effectiveness. However, there have been 2 different studies, 2 randomized diet studies in EOE. The one on the left is in children. This was a single food with milk versus a 4-food elimination diet. The one on the right is in adults, a single food milk versus a 6-food elimination diet. And these studies actually really surprised us because it suggested that eliminating just 1 food was not all that inferior to eliminating more foods in the diet. So it suggests that you could just do milk elimination as a start for some patients. Now, interestingly, in the adult study, 45% of patients who failed this 1 food went on to respond to the 6-food elimination diet. So some patients want to start with a less restrictive diet and then build up to more restrictions. This is a reasonable approach as well. What about real world experience? We've been talking a lot about diet therapy in clinical trials. So we looked at our own data at Northwestern on patients who just did this as part of clinical care. They weren't part of any clinical trial. And we looked at 213 patients, and 54% had a full histologic response, meaning all those eosinophils went away on the diet. Some of those patients who didn't respond initially wanted to keep going because they thought maybe they had exposed themselves accidentally or had a contamination. So that number actually went up to 58% with subsequent rounds of diet therapy. But the most interesting thing that came out of this study that we talked to our patients about before even starting diet therapy is that 69% had only 1 food trigger identified. So that's really helpful to know. If the majority of patients have just 1 food trigger identified, then it's easier to wrap your head around eliminating 1 food moving forward than eliminating all 6 foods. So I think that's a critical piece that came out of this. Now, there have been follow-up studies from Italy that show that diet effectiveness may decrease during high pollen months. So if you have someone who you think is really going to respond to the diet, they feel so much better, but they still have some eosinophils, it might be helpful to talk to them to see if some of their air allergens or their allergic rhinitis or their seasonal allergies have been really ramped up around this time, because that can explain why you may not have achieved that response. Now, we've talked a lot about this top-down strategy, meaning taking all 6 foods out, taking all 4 foods out. What is a step-up therapy? A step-up therapy is starting with a less restrictive diet and then eliminating more things as you find, as you do not achieve response, so to speak. So I'm going to walk you through what that means. So step-up elimination diet approach, essentially, first of all, you can take your 2 foods, top 2 foods, milk and wheat. And this was a study done in the Spanish group. If you eliminate those 2 foods, they had a 44% response. Patients who didn't respond and wanted to pursue diet therapy were then stepped up to a 4-food elimination diet. So milk, wheat, soy, and egg. and they got a 60% response. The patients who didn't respond here were then stepped up to the traditional 6-food elimination diet, and that resulted in about an 80% response. So again, it just suggests you could start off with fewer foods. If they don't respond, you can take some additional foods away and then build upon that initial diet. One of the most important things that we need to talk about in terms of diet therapy is food reintroduction. We don't want to eliminate all these foods and keep patients on multiple food elimination indefinitely. The goal of diet therapy is really to reintroduce foods and find those food triggers. Now, this was a protocol that we used with the 6-food elimination diet, but you can use this if you're doing 4 foods or 2 foods. We just start at different points. So I'll just walk you through what it would look like as the 6-food elimination diet. So if you're in remission after that 6-food elimination diet, we started adding foods from the least likely culprits to the most likely culprits. So we would add seafood for 2 weeks, nuts for 2 weeks, and then do an endoscopy. Assuming patients were still in remission, we would add soy for 2 weeks, egg for 2 weeks, and then do an endoscopy. Assuming they were still in remission, then we would add wheat for 4 weeks and do an endoscopy. If they were in remission, add dairy for 4 weeks and endoscopy. Wheat and dairy got their own endoscopy because they are high culprit foods, so to speak. And in some cases in pediatrics, they may do single food reintroductions because there's a higher likelihood that there may be multiple food triggers in that group. If at any point someone reacts to one of these foods, then we have to do a little bit of a back step. Then it means taking out one of these foods, kind of washing out that system, meaning eliminating that food for about 6 weeks, getting that esophagus healthy again, and then proceeding on with the food reintroduction. So it's a process. By all means, diet therapy is a process. It's important to talk to patients about this whole process before they embark on diet therapy so that they know what they're getting into. Again, as you heard from Dr. Muir about maintenance therapy and medication, maintenance therapy with diet is just as important. There's data here looking and showing that long-term diet therapy is effective. This is data out of North Carolina, effective in about 50% of patients. And this was a 2-year follow-up. The patients who kind of fell off the grid here were patients who had trigger reintroduction or they just had poor compliance with the diet. But those that maintained response were still in remission. That was about 50% of patients. We asked our own patients to try and did a survey to try and identify factors that affected their adherence. So this was a survey study on patients who went through the 6-food elimination diet. And 57% who completed that diet initially were still on maintenance diet therapy, so not all that different than the North Carolina study. We asked them about what factors affected their adherence, and what they said was diet effectiveness of reducing their symptoms, difficulties with social situations, diet-related anxiety. Those are things that made them not want to continue the diet. But what was really interesting about this study is that the majority of prior diet and current diet users recommended diet to other EOE patients. So they felt that there was a benefit to actually having some control and knowing what their food trigger was, even though they may have, modified to medication down the line. And additional studies from Spain, the follow-up step-up study, when they looked at their patients on diet therapy, 100% of patients who maintained diet therapy were still in remission at 3 years. So it does suggest that if it works and patients want to do this long-term, it is effective. So we walked you through a lot of data behind medical therapy and diet therapy, as well as maintenance therapy. I'm going to go through a couple of the highlights, and we really wanted to prioritize leaving time for questions and discussion at the end. So in summary, the goals of therapy in EOE are to achieve symptomatic, histologic, and endoscopic remission. We don't want to hit just one of those targets. We want all 3 in order to know that we've achieved an appropriate therapy. First-line medical therapies include PPIs and swallow topical corticosteroids. Dupilumab can be used in a step-up therapy for refractory patients or in patients with multiple comorbidities meeting the criteria for dupilumab. Empiric elimination diet is the favored diet therapy. less restrictive elimination diets can be used. And importantly, food reintroduction followed by those serial endoscopies are indicated to identify food triggers. You don't want to keep patients on these really restrictive diets for a long period of time. And regardless of therapy, whether it's medication or diet, maintenance therapy is advised as EOE is a chronic disease. So we have left a lot of time to have a discussion, and please, if you can use the Q&A function and send us your questions in the Q&A, we're going to start going through that and walking through some of your questions now. So I'm going to pull those up, and we'll start with the first one, and we'll kind of go back and forth. Dr. Mira and I will just kind of divide and conquer some of these questions. So the first one is for PPI dosing. Is BID dosing better than Q-day dosing? And if a patient has not had a response to Q-day dosing, should we try BID dosing first or move to a different treatment? So, and very excellent question. So there were studies that showed that BID dosing, omeprazole 20 milligrams twice a day, was superior to once a day dosing. And why that was, no one really understands, but maybe it's just having a more suppressive state for a longer period of time and this anti-inflammatory properties of the PPIs. So BID dosing at 20 milligrams twice a day is more effective. However, the caveat to that is patients really have a hard time with BID dosing. So the adherence really falls off. So in my own clinical practice, I do the equivalent of omeprazole 40 milligrams once a day. And that is fine with me. And if they don't have a response, then it's fine to move on to other therapies. I think the critical thing is defining what kind of response they have. And at least on the adult side, and I'm curious that I'll have Dr. Muir fill in on the pediatric side, but on the adult side, we see an excellent response with PPIs, about 50%. Whether or not that's people have this combined reflux and EOE phenotype, but we do see a good response, and rarely do patients not have any response. They may have a partial response. And if they have a partial response, then we keep them on the PPI, and then we'll add either the topical corticosteroid or keep them on the PPI and then move to diet therapy. We don't remove that PPI if they have that partial response. If they truly have zero response, then it's not unreasonable to remove that PPI and switch to something different, but that's what we do. The other caveat is that there are some patients who might be CYP219 hypermetabolizers, and they may hypermetabolize omeprazole, and they may still have distal disease. And those patients are people that I would switch to rabeprazole 20 because that is not metabolized by the CYP219 pathway, and that has been shown to be effective. There have also been studies that suggest that patients who have more distal eosinophilia are more likely to respond to PPI therapy than those who may have pan-esophageal inflammation. So Dr. Muir, what do you think in the pediatric population? How does this differ? How does your practice differ?
I think our practice is actually pretty similar because the compliance is so much better with a once a day dosing. However, if say you fail the once a day dosing and the patient really wants to try twice a day dosing before giving up on the PPI, I will offer that if they are, I really want to give it one more try before I go to step up my medication. What if we just try it twice a day to see if that's how I metabolize it better? And I think it's an option.
Yeah, great. And then the next question kind of spins off this. Is there a meaningful difference between omeprazole 20 milligrams twice a day and 40 milligrams twice a day? So if a patient does not respond to the lower dose, would you escalate to 40 BID before moving to a different therapy? And I think this really comes down to that shared decision-making conversation, as Dr. Mira just pointed out. Potentially if that patient really wants to escalate therapy before switching, that's not a unreasonable thing to do. I will say there's some data from Mass General that suggests that higher doses, even omeprazole 40 milligrams twice a day, can capture patients who have lost response to PPI. So it's not unreasonable if you want to drive up that dose to 40 milligrams twice a day and then see if they respond. Sometimes I'm finding more and more of these patients are having that CYP219 hypermetabolizer state, so I will do that switch to rabeprazole. What about you, Dr. Muir? Do you think you drive it up as high as 40 twice a day?
We definitely do. And in kids, in the younger kids, we try to do 2 mgs per kg BID. And so it divided BID. And so in younger kids who aren't quite 40 kilos yet, we do think about what their weight is and how do we optimize their dosing per kilo. But I agree with you. It ends up going back to shared decision making and what's our tolerance and how symptomatic are they?
Okay, so I'm going to ask Dr. Muir. The next question is, what's your preferred first-line PPI for EOE in terms of agent, dose, and frequency?
So as far as agent, unfortunately, in the world we live in, I will say it somewhat depends on what will be easily approved and what will be tolerable to the patient. So many of my patients cannot swallow pills, and so we rely on a lot of packets. It's nearly impossible to get anything compounded. So we tend to really lean into the medications that come in packets, but I don't have a specific PPI that I necessarily go to other than thinking about a solutab versus a packet versus a capsule, and what will the patient more likely tolerate.
Yeah,
And
I would say it's very similar in our practice. And I would one thing I just want to chime in on, if everyone that's putting in questions can please put it in the Q&A. It's hard for us to toggle back between the chat and the Q&A. We will get to everyone's questions, I promise. But if you don't mind just retyping it in the Q&A, that would be really helpful. So I think our practice for the PPI is really very similar. A lot of it is what insurance is going to cover. I don't think 40 milligrams of omeprazole once a day is unreasonable. But sometimes it also depends on pill size too.
Mhm.
Sometimes if people have a really bad stricture, I might start with rabeprazole 20 because it's tiny. Or if we do omeprazole, we might have them open up the capsules and mix it with applesauce, or, in some cases, as Dr. Muir mentioned, doing a solutab. So sometimes that drives the decision, but a lot of times it's, insurance coverage of these medications. There hasn't been great head-to-head studies saying that one PPI medication is better than another. So the next question is, why is Eohilia approved for 12 weeks? What are we supposed to do after 12 weeks? Dr. Muir?
That's a good question. I write a letter of medical necessity, and I put that specific paper showing the 4 months of efficacy. I mean, the 4 years, the 48 months, and now and giving us long-term data. And I have yet to have that fail to get approved once they're given that data. So I think it's just a matter of showing that this is saying in your letter, this is a lifelong condition. We need chronic therapy, and there is evidence that this medication has been efficacious long term. I'm not sure what you do.
Yeah, I mean, similar. I think we know that swallow topical corticosteroids are very effective therapies, both for induction and maintaining remission. And we don't just stop after this time. I think the rationale for the approval was that they didn't meet certain symptomatic endpoints at the time of that study, and therefore that's why they got that 12-week approval. But there have been showing and publishing, this long-term data, which is very compelling at maintaining remission. One thing I do, however, is whether or not it's budesonide oral suspension, or whether or not it's the oral viscous budesonide, whether or not it's a compounding medication, I will reduce the dose down.
Mhm.
So while the induction dose is, for budesonide oral suspension, 2 milligrams twice daily, or the studies with oral viscous budesonide, 1 milligram twice daily, I will maintain a once a day dosing for maintenance, usually at night, and it's usually about 1 milligram. Or if it's in the 2 milligram packet, I might try to do 2 milligram every other day. I really try to de-escalate to that lowest dose possible. And once I de-escalate that dose, I will follow it up with an endoscopy in about anywhere from 3 to 6 months, to just make sure that lower dose is still achieving that histologic remission. All patients want to minimize their medications. We do know, based on some of the studies with the budesonide oral dispersible tablet and other budesonide studies, that going too low will result in a recurrence. So it's a little bit of a fine balance, but patients all want to try to decrease medications as best as they can. And ideally, if you can do once a day dosing, it helps with adherence.
Mhm.
And that goes to the second question here in terms of steroid dosing. Is twice daily dosing better than once daily? Compliance has been an issue in some of my patients.
And I think there is nice data out of North Carolina that, especially in the patients who are taking the ampules or the inhaler, that you can consolidate all of the dosages you would give in a day. So in a patient who's on 1 milligram twice a day, I think you could make that 1 milligram and plus 1 milligram, so 2 milligrams of a slurry once a day instead. I do think that improves compliance and it seems to have similar efficacy.
Yes, for sure. And then I will say, I usually try, if we can get down to that once a day dosing, I tend to do it at night, right before bedtime. So that way it gets kind of that maximal contact time with the esophagus. As Dr. Muir mentioned too, making sure that we're telling our patients to rinse out, their mouth, gargle, spit out water, don't eat or drink for about an hour after use. That hopefully will minimize some of those side effects of the thrush or the esophageal candidiasis, but it's easier to do sometimes when it's right at bedtime as opposed to trying to time it another day. So that's another way I try to, encourage adherence that way. So the next question, is it safe to prepare a larger batch of budesonide suspension once weekly, or should it be mixed fresh for each dose? So, I would say, you want to take that one?
I've never been asked that before. I feel like this is a new
Oh,
one
I've
for
been asked
me.
that before by our
Oh,
patients. So, I think the question is, we don't know, right? In terms of the different formulations, they're designed to be delivered in a certain way. They're shelf stable to a certain time point. So I really discourage patients from like making up a whole batch and keeping it together, keeping it for long term. The one caveat with this is that if you have a compounding pharmacy and you can use them to create a bottle of the oral viscous budesonide that is shelf stable for a period of time, then they can have a batch. But I really discourage patients from, taking the oral viscous budesonide and making up a whole batch packet of the, budesonide oral suspension and keeping it, because the properties are just not the same and it wasn't designed to do it that way. So until we have something else that's, designed differently, I typically don't advise that. Any role of barium esophagram in managing EOE?
maybe. I think there are some roles. I think that, it kind of depends on what your questions are. So oftentimes I will use this, especially in patients where I'm seeing them after their initial presentation with a food impaction. And mostly so that I can prepare, especially since I have pediatric patients and preparing for a dilation is slightly different than potentially at an adult hospital. But just to kind of get a sense of the landscape in someone I know who has some remodeling in their esophagus, to just look and say, is there anything there? And the thing that seems to be growing in popularity in this type of field is considering doing a barium tablet as well, because that has a diameter of 13 millimeters. And so you can really get a sense of, is that 13 millimeter tablet getting hung up in a specific location, and then really plan to dilate from there. Because I don't think that the liquid esophagograms have as much sensitivity as the barium tablet ones. So I think kind of taking those things into consideration, because with the esophagograms, you do sometimes get burned as it we read as totally normal, and then you'll go in there and there'll be a stricture. And I've also had it the opposite, where they read it as, a narrowing or a Schatzki's ring, and you go in and there's absolutely nothing. And so I think the esophagograms don't have very good sensitivity or specificity, but I think they're helpful in a certain population of patients.
Yeah, I would agree. I think in adults we use it more. Not knee-jerk barium esophagram for everyone, but there are certain circumstances where I think it's really helpful. And we don't do a timed barium esophagram for this. That is done for motility etiologies, but an air contrast barium esophagram with a swallowed tablet. And as Dr. Muir said, it is under a certain size for that critical stricture. So barium tablets were designed to be 12.5 millimeters because those critical strictures, as she mentioned, was about 13. So you know if a barium tablet is getting caught, like there's something critical there. The times that I use it is if patients come to me and they say they've had such a long-standing history of dysphagia and they're localizing a lot of things to the very top of their neck. I do the barium swallow with the tablet because sometimes cervical webs or cervical strictures or very proximal strictures can be very tricky to see on endoscopy. So that could be a helpful roadmap. If I've done an endoscopy, I feel like it's really normal. I've done an empiric dilation. I don't see anything. No disruption has happened, and they're still complaining about dysphagia. Sometimes I will do it to rule out other neck etiologies, such as something called a cricopharyngeal bar, which could push in on the outside of the esophagus and create dysphagia. But always I will use a tablet. But if the esophagram is normal, I wouldn't necessarily tell a patient, you don't need that endoscopy. I think the endoscopy is much more sensitive and has the advantage of achieving that tissue diagnosis as well. And also critically, if you do a high quality endoscopy, you'll be able to pick up on some of these strictures. So those are some of the times that I've done that. Also, if someone has come to me from elsewhere and they said that they couldn't pass an upper scope, then I'll do a barium esophagram just to know what tools I need to have on hand. We've had people with a stricture so small that, we've had to dilate under fluoroscopy. Even the
Mhm.
pediatric camera can't go through. So there are circumstances where I feel like it's very helpful. There are some questions here from last month's meeting. Should we obtain gastric and duodenal biopsies at baseline? If the diagnosis of EOE is not made initially, since histology is not yet available, should these biopsies be obtained during follow-up endoscopy? So in terms of that question, I'll take that one. So if you are doing a baseline endoscopy on someone and they do not have any other symptoms, and you have to really probe them on lower GI symptoms for non-EOE EGID, like abdominal pain, nausea, vomiting, early satiety, bloating, change in bowel habits, lots of different things, or they have a peripheral eosinophilia, or they're really atopic. If they don't have any of those things, the yield of doing gastric and duodenal biopsies, we did a study of this at Northwestern, it's less than 5%. It's really, really low. So if you don't have symptoms and you don't have endoscopic features, then I don't routinely do that. If someone has a peripheral eosinophilia, if they have some of these vague symptoms, or I see nodularity, erythema in that stomach, I see, a little bit of loss of vascular pattern, then I will routinely take biopsies in the stomach and the duodenum. And you want to take at least 6 to 8 in the stomach, ideally in the antrum and body. That's usually the highest yield for non-EOE agent, and 6 in the duodenum. And similar to the esophagus, you're going to target those areas of abnormality. You're going to target those areas of abnormality in the stomach and the duodenum. And is it acceptable to place all EOE biopsies in a single jar if there's low index of suspicion in some cases? So I would say, typically when I'm doing endoscopy and biopsies for EOE, and I'm seeing inflammation and I'm seeing endoscopic changes of EOE, I put them in separate jars, both at baseline and after treatment. It's very helpful to know what still is inflamed. If you're doing an endoscopy and for dysphagia, that esophagus is perfectly normal. I'm talking about adults now, like truly perfectly normal. And you're just doing biopsies because our, consensus guidelines tell us we have to do biopsies. There are some cases that I will put it in one jar because my suspicion of this coming back abnormal is really low. There's a caveat though, and Dr. Muir is going to tell us why, because it's a little different in pediatrics.
So I will say that we sometimes run into, I don't know which caveat you were talking about, but I was thinking that So in kids, we always take duodenal and stomach biopsies, but I do think that if you see anything abnormal, taking 6 from the stomach as opposed to the 2 that we normally do from the antrum and making sure that there's adequate sampling across the board is extremely important. And in as far as sampling the esophagus, I will often put everything in one bucket, especially in the setting. I mean, at our institution, there are additional charges. So especially in the setting where the entire esophagus is a uniform appearance, I may place everything in the same bucket. However, if there's differences in the upper and the lower, and that I always put everything in different buckets. So if there's different appearances at different parts of the esophagus, you want to make sure you separate those buckets because so you can know where the pathology is coming from.
Yeah, those were my caveats.
Oh, okay. Okay.
And the fact that, in children, the endoscopic appearance could be normal.
Oh,
So,
yes, that's true too.
it's not typically normal in adults. So that's why I'm saying if you're really seeing a normal esophagus, I mean, the likelihood of it being EOE is truly low. That's very different in kids where they can have a normal appearance.
And I
Go
will
ahead.
add one more thing. I'm sorry. In kids, we have to remember we do a lot of scopes for failure to thrive, just vague failure to thrive, especially in the under six and under population. And I find that those kids are the ones that are most likely to be missed because they're inadequately biopsied. And so we really have to make sure when EOE is even a hint of on your radar, like this patient, the reason you're scoping them for failure to thrive is because your suspicion is likely for EOE. You have to make sure you do 6 biopsies of the esophagus in that case, even if it looks totally normal.
Yeah. Yeah. And so that, I mean, that is really critical. So when we're talking about the biopsies, doing at least 6, we actually do 4 in the lower, 4 on the top. So we're like overachieving here with 8. But
Mhm.
not only that, we're also targeting areas of abnormality. So that's really important, is making sure you're targeting the furrows, targeting the exudates, targeting those features that are abnormal, because that's going to increase your yield for sure. So the next question is, for the 6-food elimination diet protocol, EGDs are done how often after food reintroduction? So there's no standardized approach to this. I think you can ask every center in the country and we'll all say something differently. I'll just tell you what we do, have Dr. Muir kind of fill in what she does. So after 6 weeks, and we do diet therapy for 6 weeks in adults, we know that within 6 weeks, the esophagus is going to resolve, and we don't need to do it any longer. And adults don't want to do diet longer than 6 weeks. That's about all we can, do. We don't want to torture them more than that. But 6 weeks, we'll do that first endoscopy. If that is in remission, we're doing the 6-food protocol. We have been able now, we've had years and years worth of data that the seafood and nuts are not big triggers for our adults. So adding seafood for 2 weeks and then, being in touch with them based on symptoms, adding nuts after that for 2 weeks, and then doing an endoscopy. So 4 weeks after that, we'll do an endoscopy. They tend to clear. Then our next step is to do soy or egg for 2 weeks and then build upon that with soy or egg, the other one for 2 weeks, and then do an endoscopy. And then they tend to clear. So 4 weeks and 4 weeks. And then at the end, we'll do 4 weeks of just wheat and then 4 weeks of just dairy, or we'll flip flop them, depending on what patients might have a suspicion. Some patients might say, you know what, I really feel like it might be dairy, and then we leave dairy to the end. Some people might say it might be wheat, and we'll leave wheat to the end. But we've been able to get through it a little bit quicker. If someone is really atopic, they're really allergic, they're very concerned about reactions to multiple foods. Like I said, we were lucky in that most of our patients had one. We definitely have some patients with multiple. We might do single food reintroductions and endoscopy after each one. Dr. Mira, how does your practice pattern differ in kids?
So because we don't want, our area where we don't want to be is that we, start off at say 40 or 50 eosinophils. We eliminate 4 or 6 foods, and we mostly do 4 foods in kids. No one's eating fish, and there's very little nuts. But we usually start off with 4, and we do 1 at a time, and we usually give them a full 12 weeks in between each food. mostly because we don't want to end up where we're at like 15 on the nose or something like that, and we haven't given them quite long enough to respond because it's not that easy to rescope a kid multiple times. And so I think we just end up giving at least 8, if not 12 weeks, especially when eliminating milk or dairy. We try to give them a little longer to have a longer washout off of milk or off of dairy, I mean, off of wheat or off of milk, just to make sure we know what we're treating. And we also tell patients, they accidentally had a cookie at school and their scope is in 2 weeks. What do? We try to give them a full 30 days of being as compliant as possible going into the scope.
Yeah, and that piece is really critical, having a conversation. So if you're starting diet therapy, it's really a conversation with you and your patient and the dietitian throughout this whole process. It's a huge partnership. And we tell them, and we'll do spot checks with them during this process, but we'll also tell them if you had an accidental contamination, if you went out to a restaurant and got, milk by accident, then we will push back that scope as well. And we'll push it back based on the severity of the
Mhm.
amount of food that they've had, because of course most people will do diet once and you want them to succeed and you want them to be able to get some answers, so sometimes it means like pushing back that scope. The next question is, if that initial 2 food did not identify the first 2 eliminated foods as culprit triggers, why are those foods still excluded when escalating to a 4 food? That is a brilliant question, because you would think that if you didn't respond to the first 2, you can just swap out those 2 foods and take out 2 more. And it really does not work that way. It's fascinating. But what will happen is you will eliminate more food. So you'll go up to the 4 foods. You may get remission at that point. And then when you add the foods back to identify the triggers, the majority of times it is those initial 2 foods, the milk and wheat. And we've seen this when we've done a 4 food escalating to 6 food. And no one knows why this happens, but there's some speculation that maybe taking out more foods kind of resets your immune balance, resets that allergen balance, and allows you to go into this deep remission. And then you can uncover the triggers. But the wrong thing is to say, hey, you're going to take out milk and wheat. Oh, it didn't work. All right, so go ahead and eat milk and wheat. Now let's take out soy and egg. Oh, that didn't work. Okay, now we're going to, and patients get very frustrated, and patients don't understand either when you say, well, why can't I have those 2 foods if it didn't work? If you explain to them that there's something that's going on beneath the layers of the esophagus where it isn't resetting things, that's helpful. Dr. Mir, what do you think about that in your kids?
No, I know that in kids, I think we see more multiple culprits
Hmm.
than in your population. So I think just because the kids overall are more atopic as well. But I tend to think also that, when you eliminate the first 2, it's probably one of those, but then also what else you're eating. And we do see a phenomenon, especially in this world where everybody is drinking a pea milk based product like a Kate Farms or a Ripple, where when we remove milk, all of a sudden their pee really goes up through the roof. And then they've added on a whole nother antigen in a large quantity. And I do think some of the kids start reacting to having a very, very high pea or soy or alternative milk product food in their diet all of a sudden. And so, because you're not just removing 2 foods, you're also adding one potentially to fill in the calorie gap for those other foods. So I think we run into that in kids more often because I can very easily tell, Nimmy to not drink milk and just have water instead. But I can't say that to a 3-year-old. So
Yeah, it's funny that you mentioned that, because we have the same phenomenon in adults,
mm.
because slightly different things, but when you're eliminating all of these things, some people will like drive up their corn intake and
Oh
then
yeah.
start, reacting, or drive up that legume intake from pea protein shakes.
Yeah.
So there is something where they're mixing up that immune balance, and may have been tolerant to one food and now they're overwhelming their tolerance, and that's why they're reacting. So yeah, there are definitely things to think about when you're doing these type of diets. The next question is, are there newer therapies on the horizon? Dr. Mira, what do you think about that?
So I think the most of the things that are kind of coming in that are phase 3 and phase 2 are all attacking the TSLP, which is the alarmin, that cytokine that Dr. Gonzalez told us about earlier on. And that's really the being released by the epithelium and calling those T cells into action. And so I think that this is thought to be even more upstream than the IL-4, IL-13 pathway that's working. And so hopefully thinking about these more upstream pathways will be a promising target as well.
And then if someone has very mild symptoms, when do you repeat an EGD to make sure therapy is adequate? I think it really depends on what therapy you're doing. I do think it's important to repeat that endoscopy and not go based on symptoms alone, because a lot of our patients really do modify their diets. They have a lot of adaptive behavior. So it's really imperative that you rescope. After a PPI therapy, I typically say 8 weeks, 8 to 12 weeks. After
Mhm.
diet therapy, usually about 6 weeks. After swallow topical corticosteroids, 8 to 12 weeks, and after biologic therapy, about 12 weeks, like 4 to 6 months. And those could be longer in the pediatric population if you're trying to wait a little bit longer, as Dr. Amir said. But typically, it is advised to repeat that endoscopy to make sure that that patient is in remission. Don't go based on symptoms alone. The next question I think is an important one. Maybe we can talk about this, is the need for combination therapy, PPI plus swallow topical corticosteroids or diet plus PPI. So I would say this, typically we start with the PPI first, and most of our patients have at least a partial response. And in those cases, we will keep that PPI on board. And then if we're doing medical therapy, we'll add the swallow topical corticosteroids. Same with diet. If they have a partial response to the PPI, we don't take out the PPI and just do diet. We'll add diet therapy on and then, move forward with the whole process. Once we get them in remission, it's possible that we can try and pull off that PPI. Many times, however, we've seen, at least in the adult side, we've seen some erosive esophagitis come back after we've taken off that PPI. So some patients really do have a reflux, silent. It may not have lots of symptoms, but reflux EOE overlap. But there is a role for that combination therapy. Once you've identified food triggers, ideally, you're eliminating that food trigger moving forward. But if someone's going on vacation, if it's like the winter holidays, they're doing a lot of holiday parties, it's a busy time, or they're going away to summer
Mhm.
camp and they don't want to worry about, foods when they're a kiddo, like you can use the swallow topical corticosteroids or something around that time frame. What do you think, Dr. Muir?
No, I do the exact same thing. And we can use those to kind of make quality of life a little better in someone who's very invested in diet therapy.
Yeah. And I think we have just a few more questions. If we have time and
Mhm.
people want to stick with us, we will complete these questions. When you step down your topical corticosteroids to once a day, do you have patients take it at bedtime? Ideally at bedtime to help maximize that contact time with the esophagus. And it's an easy thing to remember if it's right there, at the sink. So ideally at bedtime. Is there any role for vonoprazan? What do you think, Dr. Muir?
So it's not, there's no reason to give it to, there's no approval for anyone under 18. So I have not been able to get it for anyone, even a patient with erosive esophagitis. So,
Yeah, so it's been indicated, as she mentioned, for erosive esophagitis and non-erosive esophageal disease in adults. There is a clinical trial looking at this in patients with EOE. Certainly, speculation is that, yeah, there could be a role. I mean, even normal physiologic acid
mhm.
can affect that barrier function in the esophagus. So it'll be really interesting to see the outcome of that study. When patients have a very high eosinophil count, over 50, only in the distal esophagus, is this GERD or EOE, and do you treat for both? So there was a really nice study from Mass General that suggests that patients with distal counts had a much higher likelihood of responding to a PPI. So I do, especially in this group of patients, push for that PPI first. And I think it's also where high quality endoscopy comes to play, really looking at that esophagogastric junction, that GEJ, and making sure that there isn't subtle erosive esophagitis or a hiatal hernia, because this absolutely can be reflux overlap with EOE, or sometimes, many times, it could just be reflux that can drive really high numbers of eosinophils. So I think that's an important thing. Knowing the distribution of eosinophils can help tailor your therapy. Would you consider metabolism testing if ineffective response to omeprazole before advancing therapy? Usually I just switch. I either increase the therapy or I switch because the testing can be really expensive. It can be cumbersome. It can take a long time. And so, practically speaking, I would just switch as opposed to doing the testing. What about you, Dr. Muir? Do you do the testing or do
We
you just
don't
switch?
do the testing routinely at all. So I do think there's a world where that might be the future, where we test everyone at the outset if hopefully it becomes a more acceptable rapid thing. It would be really nice to know everybody's status before starting that. But unfortunately, I don't think we're quite there yet.
Can we cite the paper source for the
Oh, yes.
four-year study?
I feel like Evan Dallin is the first author, and it's in Clin Gastro Hep, and I think it's 2024, but I don't know more than that off the top of my head.
So we can have the
Yes,
team send that out and put that as a link with the
a good idea.
program today. Would you dilate a structure if the esophagus is endoscopically active, especially in active food bolus impaction? So this is critical. I would absolutely not dilate at the time of a food impaction. That is super high risk. You would get rid of that food bolus impaction and let that esophagus heal, have that patient brought back, and then dilate at that time. So absolutely would not recommend dilation at the time of food impaction. If it's inflamed or endoscopically active, it is fine to dilate. There's no
Mhm.
higher risk in an endoscopically active esophagus than non. One thing I will say is I base that decision based on how, symptomatic that patient is. If they're having lots of food impactions, really significant dysphagia, and they have a critical stricture, I'm going to dilate that esophagus. I'm not going to put them through therapy for 8 to 12 weeks and then wait to dilate that esophagus because we know based on
Mhm.
data and endoflip data that strictures under 16 millimeters, under 15 millimeters have a much higher risk of food impaction. Do you do anything differently in children?
No, I think we do not dilate at the time of food impaction similarly because it is such a high risk, and we often do dilate at the during active disease because we have to.
Okay. Do patients need to fail PPI, steroid, or both to get dupilumab approved? What if a patient has severe atopic conditions and would benefit from dupilumab from the get-go?
And so I think this is a good question. It's one of those, unfortunately, it depends, on a lot of factors, even like what state you live in. I think all of the different insurances have different criteria. But and I think failure is, we definitely have patients who just don't tolerate steroids, for instance, and I think not tolerating it is also very acceptable. And I do think that with severe atopic conditions, partnering with your dermatologist and your allergists is important because if a patient already was about, so I often get a call from a dermatologist or an allergist and saying, I'm going to start this anyway for their asthma, but then I was talking to them and they're having terrible dysphagia too. Can you do a quick scope so we know what we're treating? And so often we will end up sometimes skipping steps in those patients where they were about to be put on it anyway. Um, and then sometimes we have discussions about which dose to start with, but usually we start with the EOE dose since it's higher.
Okay, and in our practice, are we starting with a one food, two food, or four food? So I will say it's really a conversation that we have with our patients. We don't have as much of a response with a single food in adults. I know in children, the milk elimination is much more effective than it is in adults.
Mhm.
I think that's partially because adults may have more wheat in addition to milk. So I will say traditionally, I will talk through everything with our patients typically start with a four food, sometimes a six food. But if they really want a less restrictive diet, we'll typically do two. So we'll do milk and wheat. We typically won't do just milk. We have not had the response that they do in children.
We typically do start with one food, maybe one or two, one and two. Very rarely four.
Okay. So I think we've gone through most of these questions. There are a few more, but I think we've hit some time and we want to be respectful for everyone's evening. We really appreciate you joining us this evening, but I'm going to turn it over to Tom, just to be mindful of everyone's time here.
That was great, and our sincere thanks to Doctors Gonzalez and Muir. Before we conclude, I'd like to encourage you to take advantage of ASGE's upcoming educational events. Please visit asge.org for details on these and other great courses. Finally, please complete the post-course assessment that you'll receive from ASGE. Your feedback will help us ensure that we continue to fulfill your educational needs. Thank you so much and have a great evening.
Thanks, everyone.